Here we are. Welcome to London, guys. Welcome to London.
Thank you very much, Mr. Chairman, and thank you very much, Lorenzo, and congratulations for such a successful symposium. And I really congratulate you for raising the profile about CLTI and limb salvage. So well done. So my talk will be about the tips and tricks, which I would like to start by 2 polls, if I may. And please, I will try to be quick and I will entertain you, but just be honest with your voting, and I'm sure you are. So the first one is how many major amputation you performed, or if you're not a surgeon, you're aware of, in the last 6 months due to ischemia in no option patients. Was it no one, or less than 5, 6 and 10, or more than 10? So shall we do it with show of hands?
Exactly. Okay, give me a number.
Quick. About B, 1 to 5.
6 to 10. 6.
0. Okay.
Right, so who has any patients who had a major amputation because they felt that they are no option patients? Can we do show of hands? Right, I respect the honesty. I'll just take you to the next poll, which is if you see a CLTI patient, and this is back to again to Bruno's point about the definition of no option patient, and to Lorenzo's point, which effectively just gave away my slide. If you see someone that as a physician you think that they are no option patients, what would be your next step? Would you talk to the patient and tell them you have no options and let's talk about amputations or conservative management? Or you ask a colleague of yours, and this can be a colleague like a radiologist or surgeon or interventional cardiologist or angiologist for a second opinion? Or do you take the case to discuss in the MDM and get an MDM consensus from your unit that this is a no option patient? Or do you actually go further, and if your unit MDM says that this patient is no option, you take it further and go and speak to someone like Lorenzo or August or Dan and say, can you give a second opinion? So shall we do it with a show of hands? Who will just rely on their opinion as regards if the patient is no option or not?
Good. And it happens more, I mean, I'm not saying thank you, because it happens very frequently. And actually, it's something that we should try to involve. Eh?
Yeah.
But you put things, you ask other people, even online. I mean, it's not completely true. But I like the fact that you raise the hand, because this happens in most of the cases.
Back to Lorenzo's point, how many of us will make the effort to go and ask another opinion, for another unit for their opinion, whether we agree this patient is a no option or not? Right? Be careful, because I will ask you at the end of the...
Angus Morrison was the patient at the Jill scan today, who had a recurrent vascularization there. And he's the patient where I asked you the second opinion, because I thought, he couldn't do anything to the foot arch, performing a DVA, and then we discussed the thing and said, no, it's not worth it. Let's try conservative management. Now I have a short part amputation, and he walks with it. So essentially, it's a good collaboration. Even if you, if you think that you can be like quite, you know what you're talking about, to talk to a patient, especially from a different hospital, different views, is always very nice. And I thank you for your time.
Thank you very much. And it all works both ways as well. So what I will try to do is just to simplify. So I'm a surgeon. We'll try to keep things simple. So I will simplify how we can do percutaneous deep venous arterialization. And what I will be talking about is only the lymph flow system. So I wouldn't do any of the clever stuff that Bruno just mentioned. It's the straightforward, which is like a sort of surgeon proof. So the idea, as you know, and I don't need to repeat that, is just we reroute the deep venous system to redirect the blood, the arterialized blood, down to the foot. And to do that with the lymph flow system, you have 3 important components. The first one is the crossing system, which has 2 catheters, 1 arterial and 1 venous. And now with the second generation, we have the receiver, or the venous basket, which I will show you later. The second step, when we do the vein preparation, there is a forward pushing valvulotome. And the third step is the stenting, as we will see. And there are 2 types of stent, the straight one, and the long one, and the tapered one, which we use for the crossing. Believe me when I say the most important part to master the technique is actually before the technique. In my view, this is the most important part. It's the patient selection. And there are three main parts or points that you have to think of when you choose your patient. The first thing is the arterial anatomy. And in my view, the deep venous arterialization is a replacement of an absent foot arch. It's not a replacement of a tibial angioplasty. So it's typical for those patients where you have no named vessel going across the ankle down to the foot. Also, we've seen some pictures in the previous presentations about how calcified these vessels are. And you can look at this dorsalis pedis artery, and you can give it to any one of these clever people in the room. They might be able to open it, but how long would this last? So in our protocol, for those patients, we try to give them at least one attempt of plantopedal reconstruction endovascularly. And if it fails and they have this anatomy, then we don't go back again and try to do the same thing, because we'll have the same outcome. So this is the typical patient where they have no foot arch. But it doesn't just stop at here. What we have to do is to have ideally a backup door or a backup plan. So you have to have a vessel, which it doesn't have to be perfect, but you can optimize it to use it as the inflow for your fistula. But on the other hand, you have to have a vessel which supplies some degree of collateral to the foot. Because at some stage, when you take the flow from the main run of the foot, for example, I can't use the AT here, for example, as the inflow for my graft. Why is that? Because we will effectively cause acute ischemia by steel syndrome. So it's important to know that you have to have some flow to the foot, which keeps the foot alive until the fistula mature. The second important thing is the venous anatomy, and Jill gave a very nice talk and shared some of the very nice pictures about the anatomy of the lateral plantar vein. Before we do that, we had no clue about the foot venous arch, and even our vascular lab, who are very experienced scanners, they didn't scan the foot venous arches as well. So it's important to get familiar with that, and you have a patent and reasonable sized lateral plantar vein. The third thing, which is very important, is the status of the foot. So it's very common for these patients to have some degree of tissue loss in the forefoot, toes, and all of that, which you can manage. But I wouldn't try it when you have necrosis or gangrene of the heel, because it's not really the main target or the best perfusion you'll get from the DVA. Also, if most of the foot is gone already, so by the time you get rid of all the necrosis and gangrene of the foot, you will have nothing left, and you will destroy your deep venous arch as well. So this is not, those two on the right, they are not good candidates for DVA. Then we come to the procedure steps, and again, sort of from a surgical point of view, I try to make things simple. So when we start the procedure, there are 4 steps in my mind. The first one is to get the access, and you do that venous, then arterial. So that's number 1. You're done with the access, you cross. Once the cross is done, you go to step 3, which is the vein optimization or sort of preparation, followed by the stenting. And the last step is to optimize your outflow or the venous outflow for the fistula. Just 4 simple steps, and you go one by one by one. So let's start with the first one, which is the access. What we do is we put a sterile cuff around the ankle, inflated to 100 millimeter mercury. All of you have access long saphenous vein for radiofrequency ablation, for example. And what we do with ultrasound guidance, we try to get access to the lateral plantar vein. And what we tend to do is to use a pedal access kit, and we use a V18 to get through it. Sometimes the wire might go into the superficial system, which is not your target. My advice, don't take it out and try to reroute it. Just leave it in place, put a body wire, and try to get it into the deep venous system. Because if you look, sorry.
Where are you puncturing the lateral plantar? Because that's something also usually you stress.
Yeah, no, so what we do, if I go back, we mark the lateral plantar vein on the foot. So what we usually do is just try to get it as distal as possible before it dips into the interdistal space. Yes. Yeah. Because it saves you a lot of trouble as well, because there are valves in this lateral plantar vein. So the distal you go, you don't need to go and navigate the valves from an antegrade access. What you have to try to do is not to lose the access from the lateral plantar vein once you got access, because the veins can go into spasm, and re-accessing that is very difficult. Once you're happy with your venous access, you do a run with the cuff inflated, because this gives you the anatomy of the lateral plantar vein, and you can tell which one you're trying to target for your fistula. Then you get the arterial access, as we do day in and day out. And this is the time to make sure that you optimize your inflow. So do not accept any unsatisfactory inflow to your fistula, because in the previous data, it showed that this is the commonest cause for reintervention for DVA. It's the inflow problems. Done, this is step number one. The next one is the crossing. And the crossing is very simple. You have venous and arterial access now, so you do joint runs, simultaneous runs from the vein and from the artery, because you need to understand where you're planning your crossing. Once you have the run, you put some landmarks, and we put the ruler, for example. And we know that we're trying to get from the posterior tibial artery, so we try to cross from here to here, so we mark it at 29. So this is our crossing point. Very simple. Everything is, and we do those procedures with the patients asleep, so they don't move and we don't lose the position. Then next comes the crossing devices. So you have a catheter coming from the artery and has a marker, and I hope it projects well. You can see the basket in the vein. And I have to say, this made our life a lot easier, because it's a basket, when it's deployed, it opens the vein, and also it makes your target a lot easier to direct the needle. And you can see here that the marker on the arterial catheter is pointing away from the basket. So what we have to do is to redirect it so it actually pointing towards the basket. Very simple, and then you fire. What will happen after that is that you will get the wire just already in the basket. Or what you do is you retrieve your basket. And you retrieve your basket is effectively like a snaring mechanism. You take the whole wire all the way up, and now it comes from the lateral plantar veins. So at this stage, you have a wire which is coming from the common femoral artery and coming out from the foot from the lateral plantar vein. And then after that, your life is a lot easier. Just to facilitate delivery of everything, we just gently balloon with a 3.5 millimeter balloon the crossing point, right? Now, second step is done. We go to the vein preparation, and it's very simple, because you have this over-the-wire forward-pushing valvulotome that Bruno showed the photo for. And what you do is, as if exactly what we do for the venous bypasses, you destroy these valves, and you destroy it all the way down to the calcaneus here. After that, you pre-dilate the vein with a 5 millimeter balloon all the way up to almost above the crossing point, and then you gently dilate the crossing point. Now, this is not a point that you accept any unsatisfactory appearance or waste in the balloons. There's a very commonly seen point where you get a resistant valve or external compression, we don't know. And this is a point that you cannot take it. You cannot start deploying your stent like this. So you can get back the valvulotome, and you can see we're trying to break the valves again. If it doesn't work, in our hands, it usually works with the cutting balloons, just to destroy the valve. You have to obtain this picture with a fully inflated balloon before you start the stenting. Once this is done, you start the stenting, and usually we don't tend to cross below the midpoint of the calcaneus all the way up to the crossing point. And again, just before you use your tapered stent, you do an angiogram from the arterial axis, so you can make sure where is the point of crossing. And you can see the point of crossing is exactly at 29, where this is the posterior tibial, and this is where we crossed. Because this is where you need to place your tapered stent. And after you do that, you do an angiogram to see your foot arch. Right? Having done that, that's step number 3 already done. So we have only one step left, which is the optimization of the foot arch. And the way to do that is that you cross the foot arch, because you already have access from the venous arch, so to some extent having the sheath makes it easier. And then you use a 4 millimeter balloon, as you can see here. Once you have the balloon in place, this is the time that you lose your venous access, and you use the balloon as a part of hemostasis, in addition to the balloon or venoplasty of your lateral plantar vein. And this is how it looks like at the end. So this is our last patient, the one that I presented to you. And sometime at the end, before we finish, we do a run with the catheter in the stent, in the bottom part of the stent, just to see where the flow is. Sometimes you can actually get lucky and you have already a reflux in the digital veins, which tells you that this patient likely will do well afterwards. Now, the procedure is part of a package, and the post-operative care, I'm sure you've heard about it a lot, that their post-operative management is a little bit sort of tricky, and we have to be careful. There are 3 problems they encounter in the early post-operative periods. Pain, which is because of the ischemia, because to some extent you will cause some Steele syndrome. They will have venous hypertension, so this gives them pain and also causes the foot swelling. And what we've learned is that these 2 problems can be addressed by the use of nerve sheath catheter. So at the time of the index procedure, we'll put the nerve sheath catheter, and this gives them pain control for 7 days, which allows them to keep the foot up in the bed, so no rest pain, and even elevate it to get rid of the foot swelling as well. Then comes to the foot management afterwards. The key point here, already mentioned by Bruno, is to try to wait as much as you can until the fistula mature and until the gangrene demarcates and you know how much you're losing from it. A very common mistake that we've done when we started. So this is a patient who ended up with a transmetatarsal amputation. And I can just show you, you can see a pulsatile flow from the cutaneous veins. And if you look at the arterialized deep veins now, it's very strong, very pulsatile. This was a no-option patient. So at some stage, we're talking about below knee amputation. So you can see the marked difference in terms of the arterialization. And in most of the surgeons in the room, we will be happy if we have this type of skin, this type of the blood supply to close it primarily. Please do not, because we don't know actually what happens on the cutaneous level and in terms of the oxygenation and arterial supply. So they all get back necrosis of the edge. So what we've learned is that when patients need amputation, just do it tension-free. Transmetatarsal guillotine amputation, you can use skin or dermal substitutes if you want to, until it's ready for a skin graft. If you take toes off, again, don't close it, don't stitch it, just give it time with the vac dressing or whatever dressing you have until it's healed. Those patients, as I mentioned before, it's a program, it's not a procedure. So they need very close follow-up because they might, as any tibial angioplasty, they might need re-interventions for angioplasties of stent stenosis or sometimes from stealing veins, and it might help as well to do some focalization. So I'll just give you an example. This is a patient who came in with a stenosis distal to the stent, if you can see it, but you can also see a stealing vein into the superficial system. If you look at this angiogram, there are no visible arterialized digital veins. So obviously we picked up this on duplex, and he came in for an angioplasty. And I think we even needed to stent that, and we embolized this stealing vein. We extended the stent, and this is the result after the embolization. And you can see now, you can see some flow into the digital veins.
Sorry?
And, sorry.
Just a question.
Yeah.
The stenosis was after some weeks?
Yeah, so this was something like two months after the procedure, yes.
Okay. I had a lot of this stenosis
Yes.
In my experience until we started to go with the stent a little bit below, because I think this is really a calcaneus channel. At the beginning, I thought about the laciniatum ligament, then a compression. Is not this.
Yes.
Is a fibrotic area, so we have to open well. Probably we have to go a little bit. Yes. Because I think this area is a really critical area.
Yes.
To have an occlusion during the first weeks.
Yes.
usually in this point or due to the restenosis into the donor artery.
On the donor.
These are the
You're
two
spot
critical
on.
points of the arterialization.
You're spot on. If I show you, go back again and show you the angiogram of our last patient, we actually moved to with the stent a little bit lower down, so correct. This is another example of the same patient. Usually there is this stealing vein here, but after the embolization of this stealing vein and the TMA, if I show you this angiogram, probably you will tell me that this is an artery, this is an intact arterial foot arch. But this is what happens with the focalization. So just an important thing is that we talked about the learning curve, but the learning curve does not only involve the interventionist, radiologist or surgeon. It actually involves the team as a whole. So your theater team, for example, you ideally need to have like a core membership sort of the team who know exactly what needs to be done, what are the kits that we need to have in place, because it makes things a lot easier. We do this procedure in one dedicated theater as well. And sorry to disappoint you, but all what I've been talking about is just probably 2 to 3 hours from the few months journey of the patient. So it's really important as well to look at it from the bigger picture. You have to have the team support, the multidisciplinary team support for your podiatrist, if you have access to podiatrists, your clinical nurse specialist, your infectious disease specialist regarding the antibiotics, your diabetologist. All these people will be the ones who will pick up the problem. Ultrasonic angiology or ultrasound, those are the people who will come to you and say, listen, this is failing and this is going down. We also tried, because there is a learning curve, we tried to create a core group to start with, and then we started expanding. So we said 2 or 3 surgeons and 2 intervention radiologists. And we said 2 of us have to be there for each procedure. We can be the 4 of us if possible, but we at least 2 of us, and you've seen that, have to be in the procedure. So in conclusion, PDVA, when we set it up, we really should look at it as a program. It's not a one-off procedure. And that's something that we have to keep in mind when we select the patients. It starts from the patient selection. And in my mind, this is the Achilles heel for this procedure. There are lots of technical details, setup and learning curve, but all of that is manageable as long as you get the other factors right. All of them, they need close follow-up and early reintervention. So we have to get things in place for close surveillance, easy access to cath lab if required. And it's not a one-man show, it's not a one specialty show, it's all multidisciplinary, because you do the procedure, you need someone to look after the feet, you need someone to do the antibiotics, you need someone to control the diabetes, and it's really multidisciplinary team. And I understand that these slides will be available as PDF on the website, which obviously you're more than happy to use.
And also will be available then on Radcliffe as a recorded session.
Exactly.
Which is something very useful, even more than slides with PDF.
But I have to say, one of my team members a few days ago made me aware, brought my attention to this document, which is written by Dr. Doe and her team, and it's the protocols and the procedures for DVA. And if I recommend something, if you want to set up a service, I think this is a very good reference that you can use, and I think it's worth whatever it costs. So I just want to leave you with the last poll. Looking at all of that, having seen all the pictures and everything, in retrospect, and it's always easier in retrospect, in the last 24 months, like in the last 2 years, were there any patients you are aware of, or you did, or you have been made aware of, that you think could have been considered for percutaneous deep venous arterialization? It's a simple answer. It's a yes or no.
Green, yes, no, red.
Right, and with that, I'll finish my talk. Thank you.
Thank you so much.
Thank you.
One single question from Aurelio from Brazil. He came all the way from the Brazil, so I mean, like.
Thanks. I have one doubt, and also Bruno can make comments. As soon as we cross from artery to vein, how length has to be the stent? Just to bridge, or we need to be aware of the vein valves?
Sorry, once you crossed?
As soon as we cross from artery to vein,
Yes.
how length has to be the stent? Just to bridge, or should be aware of vein valves?
So the way we do it is that we stand from sort of as we said, from the calcaneus all the way up, because this addresses the valves as well, so you don't need to worry about it. But also to cross the bridge from the vein to the artery. And this doesn't mean that this is the top end of it. So some of the slides I showed here, we had to extend proximally, but we use uncovered stents for those ones, sort of drug-eluting ones.
Okay, thank you so much, Hany Zayed, for your great talk.